Hello, and welcome to Wilderness Medicine, University of Utah School of Medicine. My name is Dr. Paul Schmutz, and today we are going to be discussing wilderness dentistry treatments in the backcountry for your teeth. Let me share my screen with you and slides. I have a lot of pictures about teeth that we're going to discuss and hopefully teach you something up in the backcountry on how to be able to treat toothaches and other things that may happen, trauma to the teeth. So dental emergencies really happen anywhere. They can happen on a backpacking trip. They can happen on a day outing or a day trip. They can happen at the ballpark, and they can even happen in the backyard. So pretty much anywhere you can think of, a dental emergency can happen. So let's take for an example that we are on Cataract Canyon. If you're not familiar with Cataract Canyon, it's at the confluence of the Green and Colorado River, about 30 miles from the nearest road downriver of Moab, Utah. It's really hours to maybe days to the closest road. And if you have a friend who wakes up in the morning with something like this, the question is, are you going to be able to treat them? So your options are you could phone a friend, and there's a lot of air ambulances out there these days. But if there's something that you can do to treat it yourself, then we may be in a better shape. So today we're going to focus on things that will increase your knowledge and hopefully improve your toolkit so that you can help treat people in the backcountry if they have a dental problem. We're going to focus today on toothaches, infections, trauma, and soft tissue injuries related to trauma. So let's just look at a minute at a tooth and the dental anatomy that comes with that. When we look in a mouth, that crown that we see of the tooth that we see is the outside layer is enamel. It's just a hard substance, a hard rock, so to speak. The next layer in is dentin, which is filled with lots of little dentinal tubules that have fluid in them. And then as we get down deeper, we get into what we call the pulp chamber, which is really the neurovascular bundle of the tooth. It has the nerves, the blood vessels, connective tissue, and other soft tissue in there. So we're going to concentrate on those things, and eventually we'll talk about some other anatomy parts of the tooth. So for the next 45 minutes, we'll spend a little time in my world and discuss what happens when someone has a toothache. Basically what this is an inflammation of that pulp chamber, that neurovascular bundle that gets inflamed. It comes in two flavors, reversible and irreversible. When we have a reversible one, basically what we're going to do is just remove the cause of that, the etiology, and usually the tooth will be fine and has settled down. If the pulpal tissue has gotten a little bit farther along, even though we may remove the cause of it, that neurovascular bundle, that pulp chamber may still be irritated, still give a toothache, and we need to do a little bit further treatment on that to get things to settle down. So when we look at this, I kind of put them side by side, and the cause is kind of the same. It's either, we call it caries, but it's really just a cavity in the tooth, and or it could be a deep restoration or exposed dentin. When we look at irreversible pulpitis, we have deep caries. We also may have a disruption of the blood supply to that tooth, either an increase or decrease, which affects the nerve in the tooth, and that's why people will get a toothache. The symptoms kind of differ a little bit between the two. Usually with the reversible pulpitis, it's usually sensitive to something like hot, cold, sweets, and the pain is just while it's being stimulated and goes away once that's removed. With the irreversible pulpitis, the pain seems to linger longer, and it may be spontaneous. It may bother the person when they bite down on it, and it could be just diffuse pain, and sometimes we'll see that referred pain. So here's some examples of reversible pulpitis. This is caries that are happening on this person's tooth, and if I put something hot or cold on these teeth, then they're going to get a response to it. Here's a diagram that shows the same thing. We might have a cracked or a defective restoration that leaks. And so our stimulus again is getting down in there and is infecting the tooth. And we could be starting to get some caries down deeper that goes to the nerve. And or we may have a restoration that was placed in there that has gotten very close to the pulp and has irritated things in that manner. Or we could have some exposed dentin, so that when something hot or cold gets on there, it makes the tubules, the fluid in the tooth, get pushed down and moved and hit against the nerve and give us response. So when we look at this, we have, in this case, we had a corner of this tooth break out, and we have some exposed dentin. And so if I were to put something hot or cold on that, then the patient will probably have a response to it. So the treatment is we're going to put a filling in there. And if they still have pain after that, we can give them some analgesics to deal with the pain until it settles down. We also like to cover these up because they usually have a sharp edge right along there when they crack or break, and they can ulcerate the tongue. So in my office, basically we'll put in a filling, could be an amalgam, could be a composite, could be a gold filling. In the back country, we're going to want to put in a temporary filling. So basically we just filled this corner that's broken out in with something to help protect the tooth. And our temporary filling can be something simple as Cavit, some ZOE, which is zinc oxide and eugenol. You could put in some ortho wax or some soft wax. You could even use gum just to kind of cover up that area to help prevent it from getting the hot and cold on that tooth to make things feel better. So when we look at reversible pulpitis, we have a stimulus that affects the tooth. And what we want to do is we want to block that stimulus, making it so that the tooth won't respond to that. So basically what we're going to do is just take a temporary filling material, and here's a couple examples that we can do it on front teeth or back teeth, wherever the tooth is broken, and we fill it up. You can see that this one has been overfilled. And in doing so, we can just take a wet finger or a wet Q-tip and kind of wipe away the excess, or have the patient bite down on that and see if we can kind of break away a little bit of that so that their bite feels normal to them and doesn't have a high spot when they chew on it. When we look at irreversible pulpitis, the treatment would be to fill the hole like we did last time and give them something for pain, but also we need to first clean out any gunk that may be in that tooth. So we want to rinse it out. We can use a toothbrush. We can irrigate it. We can take some cotton pellets in there and try to swab it out, or a Q-tip or a tip of a Q-tip, whatever we can get in there to help kind of clean that out. And then if we just put the filling in, we haven't done anything to calm that nerve down. So we have to remember that we kind of have a hot tooth here, and with that hot tooth, we need to calm the nerve down. And so what we want to do is place some sort of a medicament before we place our filling in the tooth. And the things that seem to work the best is something called eugenol, which is also very similar to clove oil, which may be a little bit more readily available for people to get a hold of. And then we're going to use a little cotton pellet. We're going to soak it in the clove oil. We don't want to put it in dripping wet, but we do want to kind of have it nice and damp, and then place it in there, and then we can place our filling on top of that. Now, if you don't have clove oils, you can actually just use regular cloves. And if you put them in the mouth, you can kind of bite on them and kind of get them to kind of release their oil that's in there, and try to get that down on the tooth, or kind of crush up the clove oil and soak it up in a cotton pellet and place it in the tooth. So as we look at what we're going to have in our tooth kit here, in our toolkit, is we need to have some sort of temporary filling material. We need to have something that will medicate or soothe the tooth. And then we need some analgesics. So here's an example of an x-ray of a patient of mine. You can see these darker areas are where cavities are hiding, and definitely can make these teeth more sensitive as they eat something hot or cold. Now, if you don't have eugenol, there's some other home remedies that can be used to help remedy pulpitis. An easy one that most people have with them is some baking soda. You can either mix this pour it into some water and kind of swish it around in there, or you can dip your toothbrush in the baking soda and then kind of brush your tooth with it. You can rinse with hydrogen peroxide, 3% mixed with some water to 50%. So we're making it at 1.5%. And then also onions and cloves seem to help relieve some of the pain that comes with pulpitis. So you can see in this top picture where we have a large hole, a large defect, and that's a little bit easier to rinse out. And here we have a smaller hole, but we have a larger cavity underneath here. And so we want to do our best to try to clean that area out. And you can see on this x-ray right here, that darker, more radiolucent area that is the cavity. And so what we want to do is try to clean out the best we can. We can get in there with some floss, try to floss out anything that might be stuck in there. Usually it's food debris. You could use a little paper clip to try to get in there and pop things out, or a dental explorer, something along those lines. Once we got it cleaned out, then we can fill the tooth. Now, sometimes we might just have a filling that pops out or a crown that comes off. If that's the case, we can still do the same thing where we use our temporary filling material to fill that up. So we're going to take out our IRM, zinc oxide and eugenol, mix that up, and basically just fill in the hole. If it happens to be a crown, what we want to do is clean out the underside of the crown. And what a crown is it fits over the tooth and gives that tooth a little more strength as a restoration. So here's a crown that has come off. And what we want to do is we want to clean this area out. And then we're going to try it on the tooth, make sure it fits, and then we know which way it fits on the tooth. And then we're going to take up our filling material. Now in the office, I'm going to use something like that. Our cements are a little bit runny and gooey. And so as we put the crown on, it will express out. And then we clean up the excess as it hardens. You can mix up temporary filling material, or if you buy something at the drugstore like this Temparin, that it can also work. And what you want to do with that is just slice off a little piece of it, fill the inside of that crown, and stick it on the tooth and push it down, and it will just kind of push out and ooze out. And then you can take a toothbrush, your finger, a Q-tip, and clean up any of the excess. And that will help hold that on. So here's my dog Scout. This is when he's the most happy, is when he's out on the trail with me. And this is when he's sad, most sad, is when no one will play with him. So we're going to shift gears here a little bit. We're going to go into what happens. We start with reversible pulpitis, that if we don't do any treatment on that, it eventually will turn into irreversible pulpitis. And if we don't do any treatment there, it eventually can turn into a dental infection. And the dental infection can come from two places. It can come from the tooth, or it can come from the gums. So let's look at a little dental infection here. This is an erupting third molar or a wisdom tooth, and you can see that we're starting to get a little food impaction underneath that little bit of tissue that's still stuck on the tooth. So part of the tooth is erupted in, but we still have a little tissue left in there. What we see with this is that it's most of the time it's going to be in third molars. Other teeth that erupt in the mouth don't seem to have this issue. We're going to see localized swelling. The patient's going to complain of pain. They may have some trismus. They won't be able to open very wide, and they can't protrude their tongue very far. And the treatments for this case is we want to put them on antibiotics, give them something for pain, have them rinse with some warm salt water to see if we can clear out some of the food that's underneath that, and or irrigate that out. Here's just some pictures. You can see that tissue can be a loose flap, or sometimes it can be super tight up against the tooth. So here we are a few years back on a backpacking trip in southern Utah. And you never know who on the trip will have an issue. This is actually my son, who on the last night got bit by a bug, and his eye and ear started to swell up. And but you never know on a trip who's going to have the problem. You see this person has a nice smile, but if you look further in the back, any one of these teeth can become a problem in the back country. It can become a problem in the front country, really. And then they come see the dentist, but in the back country, it's going to be you that's going to have to treat it. And any one of these can become a reversible pulpitis or even an irreversible pulpitis, or turn into an infection because the nerve has been irritated, bacteria's gotten in there, and now we're starting to see swelling and infection starting to form, or something like this. So when we look at this, we look at the tooth infection, the odontogenic infection can become what we call an apical abscess. And usually what we're going to see here is that the bacteria has invaded either through the cavity or through a cracked tooth or through some trauma or even some gum disease. And here's a diagram. So here's our oral cavity, here's the tongue, and here's the tooth that's gone bad on us. And now it's starting to leak out with this infection. And it's going to be a localized swelling, right? Kind of in that buccal vestibule. And usually the findings are going to be that patient's going to have pain, can be spontaneous. It can be just from pressure on there. And a lot of times they'll notice it more when they're chewing, because it's what's happening is pressure is getting put down in this area where the periodontal ligament sits, and it's pushing up against that infection, and it's giving them pain. Usually the nerve has gone, has died off, so to speak, and it's no longer sensitive to hot or cold. And as that infection increases, these teeth will also become a little bit more mobile. So our treatment is going to be antibiotics, give them something for pain. And if the infection is severe enough, you may want to consider doing an incision and drainage. And what that would look like is we have a localized infection here that feels relatively soft to the touch. And we're going to take something sharp like our scalpel, and we're just going to make a nice incision, and you can see that there's pus coming out of there. Here's a patient of mine that showed up in my office. You can see the swelling right here. And another patient shows up. We have swelling here. Now on her, you can actually see the swelling is mostly on the facial, but she also has some here on the tongue side, on the lingual side. And so in the office, we'll usually open these teeth by doing a root canal, but in the back country, you're not going to be able to do a root canal. So if the swelling is severe enough, we may want to consider doing an incision and drainage to get some relief, to get that infection cleared out and start them on some antibiotics. So here's a basic diagram. We have our apical abscess. We make an incision. Now, sometimes when you make that incision, you may not get any pus to come out because it's getting blocked by the bone that's in there. And so you may have to try to dig a little bit deeper. I've had patients where I've made that incision. We really didn't get any pus out, but we've got them on antibiotics. And in a day or two, they actually felt better. So if you're not comfortable going and digging to try to get that infection out, just a simple incision may be enough, and get them on antibiotics, and they can start to feel better. Now, the apical abscess comes in two forms: in the acute phase, which is when people have pain, but also in the chronic phase, where they've had this infection long enough that now it's starting to develop this little sinus tract. And as they get an infection, as it builds up, they get this little boil that comes on their gingiva, and then it actually will start to drain on its own. And so if you look at this, the acute phase is it hasn't drained yet, and it's building up and it's causing pressure, where with the chronic phase, it's actually has started to drain on its own. And so what we look at is we're going to see localized swelling. It's going to develop a sinus tract. A lot of people call this a gum boil. The tooth may feel mobile. Some people feel like the tooth feels tall to them. When they bite down, they feel like they're hitting that tooth first. And a lot of times these are pain-free because the drainage is happening, so they're not building up a lot of pressure in the tooth. So the treatment is antibiotics, yes. Do we need to do an incision and drainage? Well, not necessarily. It's kind of doing it on its own. And a lot of times these are pain-free, but if they're having some pain, we can definitely manage their pain. So if we look at these odontogenic infections from the one single tooth, it can spread into all these different areas. We just talked about the soft tissue abscess or the acute abscess, and we also talked about the chronic abscess or the sinus tract that or fistula that develops. Next, we're going to look at the fascial space infections that can occur. And so here's our big diagram of the mouth. You can even pause this for a second and kind of get yourself oriented. But infections from a tooth can go into a lot of different places. And so if someone on your trip wakes up in the morning and they have an infection like this, we want to think fascial space abscess or fascial space infection. And here's one that is in the master space, deep in the back, and this one is going up underneath the tongue. The concern we have here with these ones is if they spread to the other side, if they get any bigger, they may actually cut off the airway. So these are important up here around the eye and then the nose is called the danger triangle, because now we have an area that doesn't have much barrier to the brain, and an infection can actually get in. A deep enough infection can actually get into the brain. So this has become serious. Signs and symptoms of these is obviously swelling that we can see. Almost like they have a little golf ball sitting there. Some of them will have difficulty swallowing. They have a temperature. They have chills. They can't open very wide. They don't look very good, and they don't feel very good. So our treatment is going to be antibiotics for sure. We always want to manage the airway to make sure that they can breathe. We may want to consider evacuation, ending the trip, and also do an incision and drainage. So again, we're back on Cataract Canyon, and our friend has developed a deep infection, a fascial space infection. The question is what is your ability to, in the backcountry, to treat these infections? And so if it's simple, like an acute apical abscess, you may be able to do it. If it's a pulpitis or irreversible pulpitis, you may do it. But as it gets into a deeper one, your comfort level may say, I'm not comfortable doing this. So as we look at the backcountry, we also want to look at what's our knowledge, what's our comfort level, do we have what we need to treat the person, and how far away from the dentist are we to get definitive treatment? Here's an example I found on the internet. You can see that this guy has a deep infection here. They made an incision. They're getting some good drainage coming out of here. And this is a few days later, because you can see his mustache is a little more pronounced and his hair is a little bit darker, and he looks a whole lot better. And I don't know if they put him on antibiotics or not, but hopefully they did. So now, if we look at our dental first aid kit, we already had the temporary filling. We had the medication to soothe the tooth and analgesics. A couple more things to add into there would be a light source so we can see inside the mouth, and some antibiotics, and perhaps some instruments. And when we talk about instruments, we're talking about a sharp knife, maybe some hemostats, perhaps some scissors, some cotton pellets or Q-tips, a toothbrush. Obviously, hopefully they have their toothbrush, some floss, some baggies, which we can cut the corner off and make some irrigation with. And I'll show you that in a second. Anything else you can think of. So let's talk for a second about analgesics and antibiotics, what you can take with you and what works. So as we look at pain management, we have our NSAIDs. Ibuprofen works great. Aspirin does good, naproxen, all those, your Tylenol, your acetaminophen, and our narcotics, of course. Now, back in 2013, Paul Moore and Elliot Hirsch did a study to see what kind of combinations work the best. And as you look at your number needed to treat, the lower that number is, the more effective that drug is going to be. And so if you look at it, they started with just Tylenol, 500 milligrams, and you can see that they got an NNT of 3.2. If they used just ibuprofen, the number was a little bit smaller. And if they used oxycodone, the number was even smaller. But what they found in this study is if they did a combination of ibuprofen with acetaminophen, that number went down to even lower than the narcotics did. So that tells us a lot in that if we use certain drugs properly, we can actually can be more effective than narcotics are. As we look at antibiotics, the mouth is full of everything. Aerobic, anaerobic, gram positive, gram negative. We pretty much have everything in there. The ADA published an article in 2019, and they kind of gave a flow chart here of, is the patient in pain? Does he have swelling? Is the tooth necrotic? Is it not? So on and so forth. Are they allergic to penicillin? And here's kind of my summary. I'll move this up. My summary of that is if they do not have a penicillin allergy, we can put them on amoxicillin, or we can put them on penicillin. If those seem to fail, then we can add things to that and or switch them to Augmentin. If they are allergic to penicillin, then we're going to use something like cephalexin, or we can use a Z-Pak, azithromycin, and or clindamycin. So we have a couple choices to pick from or to use. One alternative that I learned about from a patient who actually was a refugee in Bosnia. In a refugee camp, she had an infection, and what she described sounds like the picture that I have right here on the screen. And she said that they didn't have any antibiotics, but someone told her to get some honey and put it on a cloth and apply it to her skin. And she said within a couple of days, her infection was actually gone. So honey is a good remedy. I found an article from this tropical medicine journal that talks about the healing effects of honey. So that could be something that you carry with you, and you could use it to either eat, or you could use it to treat someone with an infection if you don't have antibiotics with you. Let's shift a little bit and let's talk about dental trauma. This is Jake. Jake is at the skate park, so he's not in the backcountry, but this can apply in the backcountry. And Jake went up, and Jake's coming down, and you can see what's going to happen to Jake. Jake hits the ground, and this is what Jake looks like. He broke off his two front teeth plus a lateral incisor. This is the picture his dad sent me from the Instacare that I went to. And oddly enough, this is actually how he showed up in my office with a temporary filling on. So the doctor at the Instacare probably didn't know how soon he's going to be to see a dentist. And so he put a temporary filling material, which we already talked about, to put on there for pulpitis. This is Jake after I got done with him. You can see that that's a little bit better smile. So as we look at dental trauma, it's going to be hard tissue, the teeth and the bones, or the soft tissue, and the gums, the lips, the tongue, the cheeks, everything else. So with dental trauma, we're going to have fractured teeth, displaced teeth, even knocked out teeth. When we look at our fractured teeth, we have different classifications for those, and we're going to run through those really quickly. We're going to start with what we call just the enamel fracture. This is really a subcategory of the crown fracture because it only involves the enamel. It's basically just a small chipped tooth. Usually it's rough, sharp edge, but it doesn't really bother them too much because the dentin is not exposed. The treatment on this is just to avoid things that bother the teeth and to try to smooth the edge until they can see the dentist. If that still bothers them, then you can put on a temporary filling or put on something to kind of cover that up, some ortho wax, some gum, whatever it might take. As we look at the crown fracture, we have a fracture of the enamel and exposure of the dentin. But in this one, we don't have any pulp involved. But these teeth are going to be more sensitive because the dentin's now exposed. Again, they'll have a sharp edge, and the tooth actually may have a concussion or a subluxation, and we'll talk about that shortly. Treatment, of course, is to put a temporary filling on there or somehow smooth out that sharp edge and to avoid stimuluses that bother the teeth. Now we've got a complicated crown fracture, which means that we have an exposed pulp along with all the other things that have been fractured off from the tooth. These teeth are going to be more painful and more sensitive. Treatment is going to be to stop the bleeding. We can put on a little soothing medication, the eugenol clove oil, and then put our filling on there. This is the crown root fracture. If you look right here, you'll see a small little line in that tooth. If I put a little pressure on it, you can see that that tooth starts to move or wiggle on us. And now you can kind of see where that fracture is going. So what our findings are is we're going to have a little piece of the tooth that's going to be loose, very mobile. It's still there because it's still attached to the gum tissue, the gingiva. In this case, we don't have any exposed pulp, but this tooth is going to be very sensitive. As they bite on it, that loose piece is going to bother them, and we may have some sharp edges. So our treatment options are going to be either we're going to remove that fragment or we're going to try and stabilize that fragment. And then after that, we'll give them whatever it takes to make them feel better. Put them on a soft diet, have them chew on the other side of the mouth, and manage their pain. So in this case, we're going to take off that loose piece because I know that it doesn't go down very far. And you can see where we've grabbed it with a pair of hemostats because it was super loose. And that's where it was attached to the gum tissue. And that's what it looked like after. We have a little bit of bleeding going on because we're getting bleeding from the gums, not from the tooth. So we can have them bite on some gauze, get that to stop. And then we can put a temporary filling in there. If we decide we want to stabilize this, then we're going to use something like super glue to kind of put it right down that little fracture or crack, and then push the tooth up against it, and then let it solidify and hold it in place. So here is our complicated root fracture. This patient came in. So this is tooth number 29, number 30, and 31. And if you look carefully, I want you to vote and see which tooth you think has fractured on us. Now remember, this is the complicated one, and it's tooth number 30, the one in the middle. And as I wiggle that, you can start to see that there's blood starting to come out. And now the question is that coming from the gum tissue or from the tooth itself? So in the back country, we don't want to start wiggling this one because now if we expose the pulp, then we're going to have to deal with making the pulp calm down and making things feel better. So ideally, we want to try to just bond that back in. But how do we tell? Basically, if the crack goes down the middle of the tooth, as you can see on this black line right here, and on this black line right there, then we're probably going to have an exposure of the pulp chamber. If the crack is off center, like this line here, or as this one comes out, then it's probably going to be not involve the pulp. So anything down the middle of the tooth, we probably want to try to leave alone and try to just stabilize it and bond it together. Here are two examples. This one has cracked right down the middle, where this one is cracked off to the side. So you can see if it was right down the middle here, then we might be having some exposed pulp. And here's the difference between these two. You can see how far down this one went compared to this one. So this one went down further. So this one's going to be a little bit harder to take out of the mouth if we're in the back country, where this one is going to be very simple because it's just basically just flapping in the wind, I guess you could say. And so we remove that. Here's that tooth we took out. You can see the crack goes down the root, and that tooth basically just kind of falls in half. So with our complicated crown root fracture, ideally what we want to do is stabilize the tooth, put them on a soft diet, have them chew on their side, and get them to a dentist as soon as possible. All right, let's talk about those luxation injuries, which I mentioned before with the concussion or subluxation. These teeth are usually displaced. They may or may not be fractured. They can be fractured. A lot of times they'll get displaced and not fracture. What's happening here is now we're involving gum tissue, we're involving the periodontal ligament, and we're involving the bone. Here's our classifications on what we're going to see here. This is the concussion or subluxation. Basically what this is someone's been hit in the mouth, tooth remains in position, there's no mobility, but the tooth is tender to the touch because it's developing a bruise or an inflammation in there. If we have the subluxation, then that tooth is going to be mobile, and we're going to see a little bit of bleeding on that tooth. Our treatment is going to be, we're going to try and rest the tooth, split it if it's loose, and treat them with the palliative treatment. And intrusive luxation means that the tooth has been pushed up into the arch. It's out of the way, and there's no mobility to the tooth. Treatment is basically just leave the tooth alone and whatever palliative treatment they need till they can see a dentist. Extrusive luxations are the ones that are going to involve a tooth that has been knocked loose, partially knocked loose. They're going to be very mobile, and they're going to interfere with the bite. And they may be knocked out quite a bit, so they're really involved, or maybe just displaced just a little bit, but they'll still interfere with the bite. So what we want to do is we want to reposition that tooth back into the socket. If it's loose, we're going to splint it, and then we'll do palliative treatment on there. Lateral luxation, the tooth has been hit hard enough that it's actually been displaced from the socket, but it's kind of been caught into that fracture zone, and the tooth is now out of position, but it's kind of locked into place, so there's no mobility, and it's going to interfere with the bite. So what we want to do is we want to get that tooth back into the socket, and we're going to do this by pushing from the top, right here, pushing down this way, and then from the back. And then we can kind of slip that tooth back into the socket. Here's a diagram of that. So we come from the top with the finger, and then come from the back side with another finger, and eventually we'll pop it right back into place. A lot of times these will not be mobile. They're locked into place. If we have a segmented fracture of the bone of the alveolar bone, what you'll usually find is it'll be a group of 2 or 3 teeth. They've fractured away from the bone, similar to the lateral fracture. But what we'll see is we'll see both sides of that alveolar bone being fractured off. So now these teeth are super loose. And the treatment is we want to put them back into position, split them, and palliative treatment. So when we look at splitting, there's rigid and non-rigid splitting. Basically, in the backcountry, we just deal with the non-rigid splitting, which is we're going to put something on that teeth to kind of hold everything in place. The easiest way to do it in the backcountry is with some sort of fishing line or a small wire or even your dental floss, and then take your super glue and just glue that onto the teeth so it kind of holds it in place. If you don't have any of that, you can use super glue just to kind of put it in approximately in between the teeth to kind of hold them in place. If you don't have that, you can be creative. You can use tape. We can use sutures. You just place that deep into the gum tissue and then wrap it around the teeth on the gum tissue on the other side of the tooth, and then bring it back and see if you can hold it in place. Sometimes that suture will be loose on the tooth. So if you put a little super glue right there, it can hold it in place. Or you can even use some ortho wax to kind of act as a brace to hold it in place. I've seen on the internet tinfoil. I've tried to see if I can figure out how to do this, but every time I put it in my mouth, I just salivate. like crazy, so I haven't found a good way to do this, or even Play-Doh or something, whatever, however creative you want to be. We're going to put that in and hold that tooth into place. So let's talk about the knocked out tooth. With the knocked out tooth, we have several treatment options. First, we can put it back in. We can store it in something. We can not store it in anything, just hold on to it. But that's not a good option. Or we can just leave it out completely and plan for a dental implant. And if you don't know what a dental implant and crown is, the dental implant basically takes the place of the root of the tooth, and then we put a crown on top to take the place of the tooth so that the patient can bite and chew with. Here's an example of the placement of some implants, and we can get a good restoration that looks just like teeth. So the success of putting that knocked out tooth back into the socket really revolves around keeping the cells on the periodontal ligament, which are right here, and on your tooth alive. And the question is how long can they stay alive without doing anything? And the common answer is usually about 15 to 20 minutes. So this is the one procedure in dentistry that is really very time sensitive if we want to see a good success with this. So in 15 minutes, we need to first find the tooth. We need to manage the tooth. We need to manage the socket, and we need to reimplant the tooth into the socket. And of course, assess for any other injuries that we may have. So 15 minutes may go by very quickly. It may take us 15 minutes just to find the tooth. So it's best if we have some sort of tooth storage system. So, you have all these things with you, or some of these things with you. Are any of these good? Well, how about water? Is that a good thing to store your tooth in? We found that water actually is not very good for the tooth. It's good for rinsing it off, but it's not good for that. So when we look at a storage medium or storage solution, we have a couple requirements. We want something that's going to maintain the cell viability. We want something that's going to promote healing, and we want it to be easily accessible, have a good shelf life, and hopefully be inexpensive. So I created this diagram of the things that seem to work the best with Hank's Balanced Salt Solution. That's what the HBSS stands for, as being sort of the gold standard, the best thing we have. And then it goes down from there. So we sort of have the good, the bad, and the ugly when it comes to solutions. And with the good, we have stuff that's highly effective and stuff that's moderately effective. So let's look at those and do a comparison. Hank's Balanced Salt Solution is commercially available. It is actually, you can buy it in a specific container here to save a tooth. It's non-toxic. It's got a good pH. It's got a good osmolarity, and you can store a tooth up to 24 hours. And the cons are you have to order it and have it with you, and there's a little bit of cost that's involved with it. These ones I put outside of the tooth diagram because they're great for cell viability, but they're not easily available. So your Viaspan and your cultured mediums can work if you happen to have those. The thing that we've actually found that works almost as good as Hank's Balanced Salt Solution and is generally readily available is milk. And perhaps you've heard that. Milk has a good pH, has a good osmolarity, doesn't have as long storage life as the Hank's Balanced Salt Solution, but hopefully you're getting that tooth back in a relatively short period of time. The key to the milk is that we want to get it into the tooth, into the milk within the first 20 minutes, because after that, then that tooth, it doesn't have any healing processes that will make that tooth start to heal on its own before we put it back in. Some people have asked about powder milk, and in the backcountry, you may not be carrying around a gallon of milk with you, but you may have some powder milk that you take with you, and that seems to work as well as regular milk does. There's also oral hydration salts. that have a good osmolarity. Some people hike with these. Egg whites work great. You may not take these into the backcountry with you, but you may take them on a camping trip. And these are two that people have tested that seem to work well. And if you use these in your daily life and you take these in the backcountry, then that would work. I have a friend that likes to drink coconut water, and that seems to be another good one that works. All of these have pros and cons to them, and you have to use, whatever is available. We've tested saliva. At first, we thought it might be good, but the problem with saliva is that it does have some destructive enzymes in there. So it doesn't, if you're storing a tooth in saliva, again, you don't have very much time, and it doesn't have very good osmolarity. Gatorade is a popular drink for people, or any of these sports drinks. The problem with them is a low pH, and again, a osmolarity that isn't conducive to good cell maintenance. And what about saline? Kind of the same thing. It is isotonic, but it really doesn't have much beyond that. Once again, we've said water is not good. And then some people have said, well, what about contact lens solution? And again, it's a buffered isotonic solution. It's better than water, but the best place for the tooth really is in the mouth. So let's talk about managing that tooth. First of all, we want to handle it by the crown, not by the root, because that's where those cells are located. We want to clean it off, but we don't want to scrub it clean. We don't want to brush it. So basically what we want to do is we want to either rinse it or soak it. And in this case, you can actually use water to do that. If there's any stubborn debris on there, you can use some tweezers or a sharp knife tip to knock it off with. And then if it appears clean, go ahead and reimplant that back in the mouth. So you can see this is our tooth that has all kinds of debris on it. That's one quick rinse. We'd pick off that one little stubborn thing, and this would be ready to go. When we look at the mouth, a lot of times this area right here, this bone, might get fractured and collapse in there. So we want to make sure we have a good big area in there. Now, the other thing that's going to happen is it's going to fill up with blood, and it's going to start to form a clot. So we're going to need to rinse that clot out, but we don't want to get in there and scrape it out, because we have periodontal ligament cells that are sitting in there waiting for that tooth to come back in so it can reattach. So here is our little sandwich baggie. We've filled it up with some sort of solution and just cut a little corner off. And now I've got a nice little stream of water that I can irrigate and clean out that socket so that we can reimplant the tooth. So again, we want to handle it by the crown, put it in. Sometimes it'll take a little finger pressure to guide it in and hold it in place. And then we want to splint it into place. Either you're going to hold it, patient's going to hold it, or you're going to splint it, put them on antibiotics, and then see a dentist as soon as possible. So in the office, again, I'm going to soak the tooth in a Hinks balanced salt solution. I'm going to check if you come in with the tooth, in milk or something. I'm going to check the socket, and then we're going to reimplant it. And then a week or so later, we're going to do root canal therapy on it. And then if it's been rolling around in the dirt, we're going to check to make sure that their tetanus is up to date. So once again, we look at the options for the knocked out tooth. We want to reimplant it, or we want to store it in something that's going to maintain viability for those periodontal ligament cells. And don't forget, time is not on our side for this one. So time is of an essence. So with that said, we're going to add a few more things to our first aid kit. We're going to have gauze or some cotton rolls or cotton pellets, transport medium. We can have that in there. We're going to have some sutures, some steri strips, tape, some sort of splinting material, something to irrigate with. And of course, we're going to have our gloves, our personal protection to use. Let's talk about soft tissue injuries for just a minute. They can happen obviously on any areas of the soft tissue. A lot of times when we want to repair the hard tissue first. And we're talking about putting the teeth back into place or reducing that bone fracture if we have it. And then we're going to repair the soft tissue. Before we do that, we want to check for any foreign materials in the tooth, especially if a tooth has been broken off. We want to make sure that that tooth has not ended up into the lip or somewhere before we do it. There's dirt or gravel that can show up in there. So we're going to remove the foreign body by irrigating, and get that as clean as possible. If it's a minor oral laceration, they'll usually just heal on their own. They don't require a whole lot of treatment on our part. We just want to get the bleeding to stop, and then we can use a warm salt water rinse just to keep things clean till the healing is completed. Wounds that require closure in the mouth are usually wounds that are bigger than 1 centimeter. If we have a gaping wound that stays open at rest, so if they cut their tongue or their lip, and or if you need something to control bleeding or for a cosmetic result. I'd like to show the picture of the split lip because we want to line up our vermilion border. That's the junction between the lip and the skin. If you don't line that up really well and then it heals up, then it'll be noticeable to everybody that sees this person. So the way you want to do that is put your first suture to line up that vermilion border and then suture from there. Here's an example of a lady who had a nice slice here, and you can see that she has healed up enough that you can barely see any scarring, and her vermilion border is nice and lined up. So that brings us almost to the end of our journey. We're going to talk just for a second about dental first aid kits and what you can do. You can buy a commercial first aid kit. Has a lot of good things in there. You can buy, but if you make your own kit, it's going to probably cost you a lot less, and you're going to have the things that you really need. So if you look at this kit, it does have some temporary filling material in there. It does have some Tylenol in there, and of course it has dental floss in there and a couple other things. But here's what I put together. Move my thing. As what I consider necessary for a wilderness dental first aid kit. Some sort of dental temporary filling material, something to soothe the tooth, some analgesics, and then here are your instruments of choice, some antibiotics, some gauze. I take obviously some transport medium to someone knocks out a tooth. You may or may not choose to do that, something to splint with. If you choose not to bring that, then obviously try to put that tooth in as soon as you can. Here's your temporary filling material. If you go down to the local drugstore, you can purchase this for a few dollars and it'll last for many years. Or you can go with the commercial one that brings you a lot of things. The basic thing is your clove oil and temporary filling material. That's what and essentially is your first aid kit. And you can buy those two things for just a few dollars and you're set to go. This is just eugenol, or you can use clove oil. So there's my kit that I like to carry with me. And I highlighted the things that we give to people in our course. And so just remember, dental emergencies happen everywhere. And hopefully we've increased your knowledge and improved your toolkit so that you can go out and do some backcountry dentistry. I'm going to stop sharing my screen now, and we appreciate you listening to our discussion on wilderness dentistry and how to treat people in the backcountry. I hope you've learned something and have enjoyed this lecture. Thanks for listening.